Welcome, everyone. Thank you for joining tonight. Okay, so thanks to everyone to joining, and thanks to Kieran, I guess, for reaching out to actually instigate this. I know there's probably a few people who have joined who actually are not from the alternate community. So bit of context, Kieran runs a gym and noticed that a lot of women around the midlife stage are starting to ask about perimenopause, and recognizing he was not an expert in the area, reached out to us to see if we could provide a bit of education on kind of the bigger picture around preparing for perimenopause, menopause, and beyond. And, you know, to be honest, everybody at Ali was really impressed that you took that initiative. So there you go, ladies. Get yourself a PT who'll do that on your behalf. It's pretty incredible. So thanks, Kieran. And we're so happy to talk about this stuff. But having said that, perimenopause, menopause is a huge topic, and we're not going to be able to cover it all tonight. We could speak for hours, days, even weeks on the topic. So we did decide that we're going to limit the scope to musculoskeletal health and make it really relevant to what you can do at the gym with Kieran. And we can touch on a few additional things as well if we have time. So with that, who are we to talk about musculoskeletal health? So we're representing Ali Health. We're a online service that focuses on sexual reproductive health. So a big part of that is menopause, perimenopause, and the hormonal changes that occur with that stage of life. I'm Dominique. I'm the founder of Ali. I am a doctor by background. However, full disclosure, I haven't practiced clinical medicine for nearly over 10 years now, but have been working in the innovative healthcare space, whether that be through different ways to deliver care, like at Ali, or on like products, innovative products. And actually the first company I worked for after leaving the hospital was for a bone health company, and I was there for many years as Director of Medical Affairs, and essentially my role there was speaking to the global experts about bone health. Many of those people have done research and informed how we think about bone and osteoporosis today, and I reference a lot of their work in my presentation. So I was really in the trenches with bones and osteoporosis, from everything from, crashing cadaver bones in, not me personally, but with the engineers to see how they'd break if you had osteoporosis versus not, to speaking to clinicians who are practicing, treating patients, speaking to the women themselves about their osteoporosis journey, and just, taking in every single aspect of bones that I can. So that's me. And so I will be speaking to you more about like what is happening in your body. But then Julia will be able to give you kind of the real world implications and the clinical slant. And I'll hand it to Julia to introduce herself.
Hi, I'm Julia. Thanks, Dom. I find your work so interesting, what you used to do in the States. Crushing up bones is a fascinating story. So I'm a GP. I've been a GP for about 17 years, and I work with women and children's health. But over the years, I've worked with, LGBTQI, Aboriginal and Torres Strait Islanders, refugees and asylum seekers, and across the board, when it comes to women's health, it's always been so poorly done, and bone health just gets ignored until they're in their 70s and they fall over and break a hip. And so my sort of mission now that I'm kind of heading to that perimenopausal phase is to really promote good musculoskeletal health.
And
Amongst many
Alex.
things, but yeah.
Yep. As Dom said, I'm a women's health physio working in Sydney. I work across 2 clinics, an obstetric and gynecology clinic, as well as a physiotherapy practice. And I guess similar to what we've already touched on, I mean, we see it in our everyday practice, in terms of the effects of aging, and particularly menopause, and a lot of women coming and saying to us, why didn't anyone tell me this earlier? Or there was so much I could have been doing, but no one told me. So pretty exciting to work in such a great space that is just constantly evolving in terms of the research and things like that.
Yeah. And, I think we take any opportunity to slide a little bit of pelvic health education in there, because a lot of women are maybe shy, or it just doesn't rise to the top of their priority list. But there's actually, a lot that can be done to improve the symptoms that come along with it. And, maybe weeing a little bit when you sneeze isn't the same impact as fracturing your hip, but if it keeps you out of the gym and keeps you exercising, then actually the long-term implications can be, pretty substantial. So it does make sense to address those symptoms when we can. Okay, so just so everyone's on the same page, a little bit about some definitions. You probably know them all, but what is menopause? It's essentially when your period ends. But when you're having your last period, you don't know it's your last one. So we do wait 1 year to make that diagnosis of menopause. And perimenopause literally just means the time around menopause. And during this time, your hormones are fluctuating, your ovaries kind of are on their way out, but they're, giving it a red hot go. And they're pretty much releasing hormones in fits and bursts. And you can see this kind of erratic behavior from estrogen and progesterone in this time. And that's kind of what we have to thank this kind of pattern for a lot of the perimenopause symptoms. It's this roller coaster. One day you've got high estrogen, the next day low. You have no idea what's coming next. But then when you do hit the menopause stage, as you can see, your estrogen and your progesterone are low. Estrogen's through the floor. And although that gives you some stability in terms of symptoms, potentially, the long-term implications of low estrogen may persist, and one of those is around bone health. I'll also note, just because testosterone is pretty hot at the moment, if you can see here, that's the testosterone line. It really starts to trend down at a pretty consistent pace from your 30s. So there's no huge or noticeable kind of drop like there is with estrogen at the perimenopause stage, but it kind of just gradually goes down and down over time. And that's partially because testosterone, unlike estrogen and progesterone, is also made in other parts of the body, not just in the ovaries. And fun fact, it actually then randomly starts to trend upwards in your 70s or thereabouts. So that has some fun effects for elderly women, and increased sex drive and whatever else. So I know I said tonight is about musculoskeletal health, but I think it would be remiss of me not to just touch on the fact that estrogen receptors are all throughout the body. And so the result of declining estrogen levels gives rise to a lot of different symptoms. It's not the same for everyone, and they can seem pretty unrelated until you make the connection to estrogen. So anything from, hot flushes, what we all hear about, but fatigue, recurrent UTIs, painful sex, take your pick. You can probably relate it to estrogen in some way. And so I make this point really just to say that even though we're talking about bone health and muscle health tonight, we do recognize that if you're exhausted, you're feeling low in mood, you're having hot flushes every 5 minutes, probably getting to the gym isn't the thing that you want to do. And so, you know, we need to look at the bigger picture and make sure some of these symptoms are also under control to get you, you know, living your best healthy habits as well. So let's get into it. Bone strength, osteoporosis, and fractures. What is osteoporosis? It simply just means it's weak bone. And your bone strength is made up of two things. A lot of people think of bone mass or bone density, but it's also about the quality of the bone and the architecture. And both of those things reduce in osteoporosis. And, you know, you don't need to be a doctor or a scientist to know if you've got a weak bone, you increase your risk of fracturing it. And that's the problem. We make the diagnosis of osteoporosis based on bone mineral density. And that essentially is just comparing your bone to that of normal bone. And that normal bone is taken to be a 20-year-old healthy individual. So everyone's bone is going to decrease over time. So it is expected that even without osteoporosis, it will decline over time. But there's thresholds that we look at to say whether you're osteoporotic, or there's something called osteopenic as well, which is where you are trending towards osteoporosis but have not yet met the threshold. And a lot of people see osteopenia as like a warning sign, but it's actually more than that, because a lot of fractures still occur in women who are osteopenic. So we ideally would like to, you know, get in and manage you before you even reach that stage. So I've included these two, you know, pretty random pictures, only because when a lot of people think of osteoporotic fractures, they think of this lady at the top, you know, the old woman who's, you know, hunched over because she's got so many vertebral fractures. And that's why you get that hunched back, because your spine is essentially crushing on itself when it breaks. Who's not mobilizing correctly or well anymore, and so is at high risk of fracture. And so that's, you know, a lot of people think, oh, that's not me yet, at least. When in reality, as I said, a lot of people who fracture are actually much younger than this and are osteopenic. So I think a study out of Geelong here did a pretty big study and said that 2/3 of women who were fracturing were either under 70 or osteopenic rather than osteoporotic. And Gwyneth, this is, you know, the picture of health, Gwyneth Paltrow, thin, got all her supplements and whatever else. She quite famously has, at least in the osteoporosis world, has come out and said that she has osteopenia, and it was diagnosed after a fracture. So just, you know, shift your mind as to what, who's at risk for these fractures. So, and then what's the big deal? Broken bone, it's annoying, but is it, you know, really impactful? And the answer is yes. We know in women over 65 who have a fracture, they're 3 times more likely to die within the year. But on a individual level, probably even more meaningful is half of those women are unlikely to get back to their previous level of independence after a hip fracture. Vertebral fractures, usually you don't need to have surgical intervention for that, so often they go undiagnosed, but the quality of life can be, you know, really disrupted. They're very painful. They can impact your mobility, and they can impact things like breathing, just because you're crushing your lungs by, you know, not maintaining good posture. And then finally, if you've had one fracture, your risk of future fractures just increases dramatically. So even if you're not, you know, managed in time and your first sign is a fracture, it's really important to try and get on top of it after that. This slide, I mean, this is just the DEXA that I was talking about, how we diagnose it. We look at different areas in this case, in the hip, and compare it to normal or to the 20-year-old. The biggest indicator or predictor of if you're going to have osteoporosis in the future is your bone mineral density at menopause. But unfortunately, in Australia at least, routine screening doesn't happen till we're 70. So that's a huge missed opportunity. And I'll leave it to Julia maybe to elaborate on that later, because there are some exceptions to the rule. But in the absence of doing a DEXA, body weight is a really powerful predictor as well. And that's not BMI, that's body weight. The bigger the person, the less likely they are to have osteoporosis in the future. So there are some conditions where we would consider early screening for osteoporosis. And once again, I'll leave Julia to speak about that later. Okay, I'd like to, in keeping with what we do at ALI, where our philosophy really is, if we give you the information, you can make really good choices in obviously collaboration with your health team, but informed decision making is so important. And to do that, you need to understand what's happening in your body. So to start, I want to just make 3 main points. A lot of people think of their bones as being relatively inert or not moving or changing that much once they've reached adulthood. And this is completely false. Our bones are constantly breaking it down and then rebuilding itself. And that's great because it means that, micro tears or micro injuries, whether it be through exercise or anything else, are repaired without adding weight. So we can stay kind of light and able to move around without having really heavy bones. So bone is dynamic, and hormones, age, mechanical load all impact the rate at which that remodeling happens. And you can see even here, so this is an area that gets a lot of mechanical load. Sorry, this is the hip. So this is the hip socket, and we call this the neck of the femur. And here you can see this is an area where even with just normal load-bearing exercise or load-bearing activities, a lot of stress is put through the hip, and so you can see that it's already a little bit stronger in that area. So it's very smart. The second thing is bone acts as a storage reservoir. So our body is extremely sensitive to the calcium levels in our blood, and our heart depends on those calcium levels staying in a very strict at a very strict level. So if calcium levels are low, the first thing that will happen, or one of the first things that will happen, is that the body will take calcium from the bones. And so this really will tie into nutrition. And once again, we can speak about that a bit later. And then finally, 2 types of bone, well, mostly 2 types of bone. We've got the thick cortical bone, which is a shell, and then the inner spongy bone is or trabecular bone, is like a lattice-like structure, and it helps distribute load, gives support, but maintains. So it essentially provides strength, but allows the bone to stay light so that we can move. Bone remodeling, you don't have to take much away from this slide, but I do want to make a few different points. I like to think of it as a building site. And essentially the osteoclasts are the demolition crew. They're coming in and they're breaking down the bone. They're releasing things like calcium, which is taken away if need be, and phosphate. And these osteoclasts are regulated by estrogen. So estrogen keeps them in check. Estrogen deficiency that occurs with menopause lets them just go wild. So we see a lot more breakdown of bone, and in a really erratic way. The faster it happens, and you can think of this as like, they're just going crazy. They're like, oh, we can break this, and they're just hacking away. That's how I think about it anyway. That's not completely scientifically grounded, but that gives you the visual of what's happening. And then on the counter is the osteoblasts, and these cells are the builders. But as you can imagine, as with anything, it's much faster to break something than to repair it. So they take a lot more time to build. So even though the osteoclasts and the osteoblasts, so the little bone builders and the bone breaker down, speak to each other and try and stay in sync, there's always a little bit of a lag because building takes longer. And then once again, estrogen just helps the function of the bone builders. So we're taking away estrogen and we're impairing the ability for those little builder cells to work as well. So that's why the estrogen decline that happens with menopause affects your bones so much. So what's our starting point? Because this is really important, and this is why some people do have osteoporosis, or some women will have osteoporosis while others won't, even though we all will experience a decline in estrogen. So essentially, following the pink line, which is women, by age 20, in your 20s, you've kind of reached your peak bone mass. And for healthy women with no other, mitigating factors, bone mass stays pretty stable until about 1 to 2 years before menopause. And then it just takes a dive. And so the point here is where you start makes a difference. And factors that impact that are genetics, can't do much about that, nutrition, exercise and strength training. There's some medical conditions that will affect your bone breakdown and building. Medications, smoking really affects your bones, and then of course hormones. But to achieve that peak bone mass, really these things are really critical, early on in life. So if you've got kids, get them jumping, make sure they're getting their calcium, et cetera, because it really will set them up to have that, optimize their peak bone mass for the future. So let's look at some cases of bone loss in perimenopausal women or menopausal women. So as I mentioned, low estrogen, rapid breakdown, increased destruction of bone, and more than that, the architecture of the bone is really affected. And then at the same time, you're building less bone. So these images here, if you can believe it, are taken only a year apart. They're a bone biopsy, so they're actual bone or their image of actual bone taken from a control patient, so a patient who wasn't taking any drugs in one of the major drug studies, and it was taken to be as representative for what was happening in people who were not doing anything around the time of menopause. So this particular lady was 52 years old, early postmenopause, and in 1 year you can just see like the dramatic change that can occur in your mainly spongy or trabecular bone. And, you don't need to know much to say that this does not look good compared to this, and this is not offering maybe the strength that you would want. So basically less bone, poor bone quality, and that's going to result in a decrease in bone strength. But so that's an individual case, but we know across on a population level, there's been some big studies that look at it as well. There's a large study in the US called the SWAN study, and part of that was looking at BMD changes or bone mineral density changes in perimenopausal women. And they followed them through the menopause transition. And the findings really were that rapid bone loss starts 1 to 2 years before, but continues 3 to 4 years after the final period. So that's, and these are substantial numbers, 10% loss in lumbar spine BMD and 8% loss in femoral neck. And the spongy bone was more affected than maybe what the BMD values suggest. So that might indicate that the loss in strength was even greater than maybe these percentages. They also showed that, as we already spoke about, fracture risk is predicted by bone density at menopause or the rate of your bone loss, which makes sense. If your starting point is low, you've got less room to move, but then also you might be in a subset of patients who just experience a more dramatic rate of bone loss than others, and that also, puts you in a bit of perilous situation. And unfortunately, there's not a correlation between your baseline BMD and the rate of loss. So you're not necessarily safe just because you have high BMD at menopause. They also looked, and we'll touch on this later, but in differences between heavy exercises and what they classified as non-exercises. And there was a small difference. I think in lumbar spine, it was 11%. In the ones they looked at, the heavy exercises had an 11% decrease versus a 13% decrease in bone mineral density for the sedentary people. So, it's something, and once again, starting point matters, but that even in exercises, you're losing bone. So it follows that, I guess, if estrogen is affecting your bone loss, then maybe replacing that estrogen is protective. And the WHI study, which ironically is the study that kind of raised warning flags about using hormone therapy back in the 90s, which have since been refuted, actually give us the best data around the benefits of estrogen for bone. And I wanted to include both these graphs, and these are showing exactly the same thing. And this is an important point I wanted to make, because when you look at the relative risk reduction, which is what's being shown here, for vertebral, non-vertebral, and hip fractures, it's really impressive. 35% decreased risk in vertebral and 32% in hip, 21% risk reduction in non-vertebral fractures. If you look at that out of context, you might say, I think everyone should be on estrogen to prevent this bone loss and prevent the risk of fracture, or reduce their risk of fracture. And this is kind of often the narrative you'll see, particularly on social media. And don't get me wrong, it is a very significant and clinically relevant reduction in risk. However, this exact same data is showing you a little bit more information. And it's just showing you that actually the rate, your baseline risk is pretty low at a population level. So I think, even in the control group, so the ones who were not taking estrogen, the risk of fracturing your spine was less than 1%. Same for your hip fractures. And the risk of a non-spine, non-hip fracture was 8.7%. Still, that was reduced quite considerably in all groups. But it looks a little bit different when you consider, I think these numbers are, I think there were 8,000 people who received estrogen, and of those, 60 who were not receiving estrogen fractured, and 40 who were receiving fractured. So the point being here, you have to take relative risk reduction in the overall context, and saying, am I at risk for fracturing for other reasons as well as, and so I'm going to take myself as an example. I look at this, I know the impact of hip fractures. I definitely do not want to experience one if I have anything to do with it. I've been in the emergency room, I've been on geriatric wards. I know how devastating they can be. And I look at this and I say, well, I know estrogen can prevent or help reduce my risk of fracture, but I'm 42, so yes, menopause is on the horizon, and that's not going to work in my favor. I am aging. That also is not going to work in my favor, because those little builder cells I spoke about before get slower with age as well. But I'm not on the low end of the weight spectrum, so that's in my favor. I've been active my whole life. Including strength training, even as a child. So my, peak bone mineral density was probably quite good. I don't smoke. I don't have any medical conditions that affect my bone. I'm not on any medications that would affect my bone. I eat everything. So I have, I'm getting my dairy, my 2 to 3 serves of dairy that I need to make sure I've got enough calcium. I get outside, I get sun, I've got vitamin D. So when I look through at my other risk factors, at this stage, I'm not rushing to get estrogen replacement for bone. Now, I might want it for those other horrendous symptoms we mentioned at the beginning, but I think it's really important for everyone to realize why they're taking something, and rather than it'll fix all the symptoms, because if you're doing it for bone loss, then really it should be part of a bigger discussion about your true risk. And the other thing to take note is there's other things involved with fracture risk, right? For your hip at least, usually you need to fall to fracture. So at this stage, I'm really clumsy, but I can still kind of catch myself before I hit the ground. So I'm reasonably confident that I won't fracture a hip through that mechanism. Now, I'll probably continue to do that kind of risk assessment as I get older and as things change. So might my decision around that. So that will change for everyone, but that's just a little bit of an example of the things to consider when thinking about, and not get scared off or sold by these population level statistics. So other than estrogen, what else is there that we can do to help our bone density? If your social media feed looks anything like mine, you're being told you need to lift heavy, and that's going to increase your bone strength. Whereas the reality is, actually, when you look at all the evidence, that's probably, there's not a lot of evidence to suggest that's the case. This is a lot of information. I purposely put labels on top of it to indicate that you're not meant to read all this. This is only to show that there are a lot of studies being done on this, and you could pretty much pick any one to prove whatever point you wanted to make, because they all vary, and they vary at the population they look at, how long they followed them for, et cetera, et cetera. But this paper did a really good job of categorizing them. And so what they did is, they say low intensity here, but they do mean weights. So low weights, moderate weights, high weights. This vertical line here is no change in bone mineral density. Anything to the right is an improvement. Anything to the left is a decline. And the circles, the black circles with the red circle around it is kind of the average finding. So as you can see in your hip, yep, exercise does help. It does build bone mineral density in your femoral neck, which is one of the areas we look at the hip, but it's not a huge amount. And ironically, the high intensity or high load regimes showed the least difference. Not many studies, so I'll give them that, but just goes to show that, yeah, that tail, I'm not sure. The evidence doesn't necessarily fit for bone health. And that's across the board. The same for total hip. Once again, follow the red dots. A little bit different for, sorry, this isn't labeled, but this is the lumbar spine. So your spine bones, your backbones. Here, maybe high intensity, high load has a more beneficial effect. But once again, very few studies compared to the rest. And the length of this line just shows the variance. So once again, not everyone responds in the same way. So the point I'm trying to make is, yes, exercise helps with bone mass, but it is no match for the really large, rapid destruction and loss of bone mass that you're going to encounter over menopause transition. And this is consistent across, as I said, the SWAN study that looked at differences in exercises versus non-exercises. It's consistent with the rate of loss we see in the control group, so the groups that didn't receive any drugs in the drug studies. And yeah, so as I said, just when you hear that you need to lift heavy for bone health, just take it with a grain of salt. And your individual starting point matters. So once again, if you've got a really strong BMD to begin with, then maybe doing exercise is sufficient. Maybe all you need to do is maintain. But if you are on the low end of normal or even lower, probably you need more support than just doing exercise, whether it be light, heavy, or moderate loads. The other point I wanted to make, I've already made it, but once again, bone mineral density is not the same as fracture risk. It is one component. Not many studies looked at the impact of exercise on fracture risk. There is one that showed that there was a statistically significant change in fracture risk, but funnily enough, that was using light loads rather than the heavy loads. So the other component of this is muscle. Another thing that we hear a lot is menopause affects muscle, and that therefore hormone therapy will improve your retention of muscle or ability to build it back. And once again, the evidence just isn't there. So this graph here shows very clearly, and this is that unfortunately, lean muscle mass in women just starts to decline around age 30. There's no rapid decline like we see in bone mineral density at menopause. It just keeps on trending down. So unfortunately, we can't blame menopause for our lack of, our loss of muscle. We can blame aging, but not necessarily menopause. And so then it follows this, forest plot exactly. Look at the same way as I explained before. This is people receiving hormone therapy, no hormone therapy, lots of studies. And this side says the people with hormone therapy responded better, and this side says the people who were not taking hormone therapy responded better, and essentially there was no difference, which makes complete sense when we realize that our muscle isn't related necessarily to menopause. But the good news is that means that just we can build muscle using the strength training principles of that when we were 30 or, before. And yeah, so I think it's good news. It's good news, but it means that we can't, people who are looking for hormone therapy to be the silver bullet to retain muscle mass will probably be sorely disappointed. And there's other factors. If it's making you feel better, if hormone therapy is making you feel better, so you're going to the gym, and that's going to help you build muscle, that's great. But in isolation, it's not the thing that's going to get you lean muscle mass. And then I just wanted to touch on this again, this heavy versus light question. Here, yes. And, Kieran, I might leave it to you to talk further about this with your clients, but makes sense to me. I'm not a trainer, but makes sense to me that if I lift heavier things, I'm going to get stronger than if I quicker. And that's exactly what this showed. So this is light load. This is heavy load. So any dots on this side of the vertical line suggest that doing a light load is better for building strength. Any dots on this side suggest that a heavy load is better for building strength. This isn't, so I should note that this isn't specific to postmenopausal women, but it's been shown that, we don't need to, the effects are the same. So, and yes, okay, lifting heavy loads will build your strength quicker. Great. But, and I know that the research group who did this analysis a little bit annoyed that this is taken out of context sometimes and said that means that lifting light or moderate loads is useless. And that's not what they're saying at all. They're saying strength can still be achieved using lower loads. It's just, it happens quicker if you're lifting heavy. So you do what's right for you. Interestingly though, if we look at the size of the muscle that's being built, they did the same study. And I found this really interesting. Actually, lifting light, moderate, or heavy loads made no difference in how quick you built the muscle mass. And so the point was all you needed to do is make you needed to get to fatigue, essentially. So it needs to challenge you, and you need to progress on it. So you need to either get heavier over time, or if you don't want to get heavier, and you're not comfortable doing that for injury risk or whatever reason, you can add more reps, as long as you're progressing over time. So the question might be, well, is big muscle better if it's not stronger? And I would say yes, because muscle is very metabolic. So that will affect with, larger muscles, well, might look nice for some people, but it also can have a big impact on things like your insulin resistance, your weight control. But for that, light, medium, heavy loads, you do what is best for you. And whatever you will do, I think we can all agree the best sort of exercise is the one that you will do and be consistent with. Okay, I think I have said too much already, so I'll just give you some takeaways. So estrogen, we know, huge impact on bone mass and strength. And the impact of this loss really depends on your individual factors and what's in your bone bank, how well you built it up to begin with and then protected it over time. Bone mineral density at menopause is your best predictor of osteoporosis risk as a woman, but body weight can also work. And you should consider an early DEXA, and I say early in inverted commas because I think actually the DEXA at 70 is late. And this is something you can discuss with your doctor, whether that's something that you should do, recognizing there's probably a cost associated with it. Estrogen therapy improves bone strength and fracture reduction risk in postmenopausal women, but it's not necessary for everyone. And that's a discussion to have on an individual basis with your healthcare professional. Exercise has a small to moderate effect on bone mineral density, but is no match for estrogen-related loss, unfortunately. And then muscle loss is not a result of menopause. And I have put an asterisk here because I'm going to say the pelvic floor muscles might be an exception to that, and I'll get Alex to elaborate on that later. And estrogen therapy does not improve muscle mass, directly at least. Gains in strength can be achieved with light loads, but progression is important, and increases in muscle size can be achieved using either low or heavy loads. Do what is right for you. Ooh, okay. I hope I haven't lost too many of you. Let's throw it over to discussion and get some real life insights. I've kind of been talking at a bit of an academic level maybe. So let's throw it to Julia and Alex to talk about the practicalities of what this means in the real world. So we'll start with Julia, and I think let's start broad, not just, I know tonight's about musculoskeletal health, but just to put everything in context, women who come to you knowing perimenopause is coming up and just want to kind of set themselves up for success. How do you approach that consult in a broad sense? And is that something people do? Is that something they should do?
It's definitely something that people are starting to do, Dom. I think there's more of a buzzword around perimenopause. So I'm definitely having people come and see me in my usual clinic or in Ali as well, asking how do they prepare for perimenopause? Like, what is it? Do I need to take HRT? Like lots and lots of questions. So I guess my approach is always firstly just being curious, what are they experiencing themselves? What are their symptoms? And you've already gone through a whole list of all of the, classical and then more atypical symptoms in your list earlier. Finding a little bit about their general health, maybe their risk factors for HRT, maybe why that wouldn't be appropriate for them. I ask a lot about their lifestyle because I think, as you were saying, the whole point of your slides, Dom, was about sort of early intervention is best. And if you can get someone in that cusp of perimenopause who may or may not be exercising, may or may not be eating very well, may not even really thought about any of this stuff yet, they're the perfect people to navigate that moment of time before their estrogen starts to kind of, because when they're coming to me at that point, like your graph showed that it's this like roller coaster of hormones. It's starting to go down, the estrogen is starting to go down, but at the moment they're still okay. From a bone mineral density perspective, cardiovascular health perspective, they're just on the precipice. So it's a really nice time to catch them at that point. So after I've taken a really big history and I've talked to them about what their priorities are, what their sort of concerns are, I personally do a bit of a dive into some of their risk factors for things like mental health, sexual health, bone health, brain health, like mood and all that sort of stuff. Because I think sometimes when you go through perimenopause, your brain feels like it's been hijacked by some outer space thing that all of a sudden you just don't work anymore and you can't remember anything. And it's like trying to work through mud. So that can be really quite helpful to people just to sort of tease out what those things are. In terms of like tests and things, like a lot of people want to have tests. They want to know what to do. And, typically hormones, as your graph beautifully showed, hormones are really hard to test because it depends in which snapshot in time you get that hormone. You might do a test today and it's your estrogen's here, and then you might do a test 6 weeks time and it's up here, and then it can be all over the shop. And I see that at work where someone has had some blood tests where someone did do some of their hormones maybe 6 months ago and it looks like they're in menopause, and then I see them and they're having a heavy period. So it's just all over the place. That's always a really good moment in time to ask them about their cervical screening and some breast screening, things like that. But I have started in my practice to talk to people about bone health as well and see if they're interested in having a bone scan. Because it's not something that people think about. People don't come to me saying, oh, I'm worried about my bones. Because you don't know that you've got thin bones. You don't know that you've got honeycomb bones that are going to break at any point, because you don't have any symptoms from that until you fall over and you break yourself. So it is kind of one of those little silent killers. So I think it's really important that it does get discussed. Unfortunately, one of the reasons it's not promoted is to get a bone density scan. And to answer one of the questions earlier, a bone density scan is essentially an X-ray where we look at the lumbar spine and the hip, and they look at the density of those two areas. It's a very quick, very simple test. But it's about $100 if you don't qualify for a rebated scan, which is actually not that expensive in the context of things. But you can't get one under Medicare until you're 70. And so if we know that your bone loss declines, by 10% in the first 5 years after your last period, you've kind of missed the boat. Like by the time you're 70, you've already got fragile bones. And so there are a few conditions where you can get one a bit earlier that people may not know about. And that's, I guess, if you've ever had, say like a digestive problem like celiac disease or Crohn's disease or ulcerative colitis, where you don't actually absorb nutrients very well. Some chronic conditions like rheumatoid arthritis or thyroid problems. Medications like corticosteroids. Some people are on steroids for a variety of skin, lung, joint disorders. What else do we do? There's early menopause, periods of being underweight for a very long period of time. So obviously we worry that maybe they've been so underweight that they've actually lost their period for a period of time. So maybe their estrogen has gone low for a period of time, or puts you at a risk factor for having reduced bone density. And you can actually get a rebated scan for those, but you've got to ask, because your GP may not flag it and say, oh, you've got celiac disease. Have you ever had a bone density scan? They may not do that. So it is one of those things that doesn't come up a lot.
And one of the questions, I was going to just elaborate on that, is how often you recommend bone mineral density scans. And I guess two parts of this question is in the early sense, the pre-70 and then post-70.
So as I said, it's not promoted as a government initiative until 70, which I disagree with. That's my personal opinion. That's not
I think
everywhere
the
else.
global
And
community
I
probably.
feel that given that the average age of menopause is 51.3 or something, we should be using that moment when someone comes into their GP with either perimenopausal questions, maybe really a change in their periods that it's kind of looking like their perimenopause or menopause, or their last period, to actually have a full health check and have all those opportunities to discuss these kinds of things. Because as you say, Dom, if you start at that point with a good density, maybe you don't need to do too much, and it's all just about maintenance with diet, exercise, that sort of stuff. But it is a really beautiful opportunity to get in and do something about it at that time.
And I think on that point, I
No,
was just going to say, in terms of the frequency, I guess
yeah.
if you're at a really high level, and you know that even a 1.5% change or 2% change every year is still not going to take you to that fracture threshold, you can probably, rest assured for a while, until something changes in your life. If you're on that borderline, then maybe, I imagine you'd
Yeah,
be.
so you get so the rebated scans, you can get one 2 years after commencing treatment, but that's talking about the sort of osteoporotic treatments. So what interval do you do it in an average person who we're kind of going off guidelines, sort of off path, sorry. It probably depends on what you got the first time. If say, Dom, you come to me, you're 40, say you're 50 and you're having your last period, and we do a scan that's good, and you've got a great lifestyle. And lifestyle is important because it's not just going to the gym, it's cutting back your booze, because, 2 drinks of alcohol a day can reduce your bone density. Smoking is a shocker for bone density, and nobody thinks of smoking and bones, but it can reduce your bone density. You need to have adequate calcium in your diet. So a lot of people don't have enough calcium, and there's this big movement for plant-based milks and things, but if they're not fortified, you actually might not be getting enough calcium. So you need 1,300 milligrams over 50 of calcium in your diet. But you also need vitamin D. And we live in Australia,
Which is
where
2 to 3 serves of calcium for those.
yes, sorry, there's so many charts on that sort of stuff.
Yeah, 2 to 3 serves of calcium a day, you're getting enough.
Yes.
You probably don't need supplementation.
And then also vitamin D, and that's either through safe sun exposure, food, but also supplementation sometimes. So when I do tests, when people come around that time, I often do check their vitamin D, check their thyroid, check their iron, check all the things that might else be causing their symptoms. But some of those nutritional things are as well.
I might change tack, just not very elegant. Oh, well, I'm going to ask, I'm not sure how they're tracking your bone mass. To the Amy W, who says one of your apps tracks bone mass. I'm not sure how they're doing that. And so I can't imagine it's useful. I'd be interested to see what they're validating that against. If it's just kind of based off your weight, I can't imagine how they're doing that.
Yes.
Sorry.
And there were 2 other good questions before about how do you die? Why do you die from having a fracture? And it's not that the fracture kills you; it's that if you fracture your hip and you end up in hospital and then in rehab, and then maybe you get home 3 to 6 months later and you've lost all of your muscle mass. Maybe you end up with a pneumonia or a urinary tract infection while you're in hospital. Your cognitive decline, and we're talking elderly people, but fractures are so dangerous in elderly people because their morbidity and mortality as a result of the fracture is what escalates things. It's not that fracture itself that kills them. And then another couple of good questions just about if you've already got osteopenia and osteoporosis, does HRT have a part to play? Very tricky question. It probably depends how old you are, because there's a magic window to start HRT. We want to start it within the first 10 years of your last period, purely because in that 10-year interval between your last period and when you start hormone replacement therapy, you might actually, because that estrogen decline, you might start building up a whole bunch of risk factors for things like cardiovascular disease, so strokes and heart attacks and things where estrogen previously was protective and is now no longer. So that's a very individualized question. It's tricky to answer, but HRT, I guess, hormone replacement therapy, the estrogen, slows down those osteoclast, destructive cells and boosts the osteoblastic building capacity. But that's a specific question. And in terms of birth control, so I guess that's the oral contraceptive pill, I assume that Melissa asked about. It's actually a really great way of protecting bones. So women around perimenopause, when they're getting very, very chaotic symptoms, we might put them on the pill, and that estrogen does help. But there's another window as well that's really good for the pill, and that's in like adolescents and young people in their 20s. If they have, say, disordered eating, or for some reason their period disappears, usually through, being underweight, it's a really good idea to put them on the pill to protect their bones and build them up as much as possible at 20 to 30 so that they're okay when they're 70. That's a bit off topic. Good questions.
I'm just going to also clarify something around Claire's question, because I don't think I was clear in my presentation. The studies around estrogen therapy were done in non-osteoporotic people, or non-osteoporotic people. So actually, we don't have a bunch of evidence as to if it works. If you're young and have osteoporosis, so within 10 years of your period but have osteoporosis, so I think generally the guidelines would suggest looking at other things, just because we don't have that evidence. And people, you can always use things off label, which is a whole nother discussion. But as hopefully I gave you a sense, like, it's so complex, and this is the same anywhere in the body. Like you affect one thing and something else kicks in. So if potentially there's solutions that have evidence behind them for their safety and their efficacy, maybe they're the better things to go for, in that particular area. So yes, the HRT studies in WHI, those women did not have osteoporosis, and therefore we do not have evidence for estrogen therapy in osteoporosis. Sorry. I just wanted to clarify that. Okay, pelvic floor. Alex, tell us, what do you see in your practice? First of all, explain to us why we should be talking about pelvic floor in a musculoskeletal talk. Let's start there. Just an easy question to start. And then maybe a little bit about, the type of patient you see in this stage of life.
Yeah, sure. So just in terms of, I guess, what we've been talking about, why pelvic floor muscles come up in the discussion about musculoskeletal and bone health and all the rest of it, is your pelvic floor muscles are skeletal muscles. So they're a group of muscles that sit at the floor of the pelvis, and above them, I don't know if you can see my model there, and it's all the red stuff. So they go from the front at the pubic bone all the way around the back to the tailbone, and they go around the three openings. So your urethra, which, sorry, you probably can't see on the screen, your vaginal opening, and then your back passage. So as I said, pelvic floor muscles are skeletal muscles. So everything we just spoke about in terms of muscles, connective tissue, bones being affected by estrogen, well, the same applies to your pelvic floor muscles. And we know, as Dom alluded to, menopause impacts your bone health in all the ways that it accelerates bone loss and increases the risk of osteoporosis, osteopenia. But menopause also affects muscle growth, recovery. It also, when we have estrogen on board, that helps maintain the integrity, the elasticity of our connective tissue. So basically, pelvic floor takes a real hit, unfortunately, as we come up to menopause and then post-menopause, because of this massive decline in the estrogen levels. And it definitely, how we see it present, and common presentation in our clinic that we at least see on a daily basis, is women that say they had quite infrequent leaking of urine. Maybe it was with a cough or a sneeze, or infrequent leaking on the way to the toilet when they were really urgent. They might have had that occur kind of seldom in the past, but then they hit menopause, or, even just before with perimenopause, and suddenly all their symptoms got a lot worse. The other one that goes with that as well is prolapse. So symptoms of heaviness, dragging, bulging at the vagina. Again, they seem to pop up a little bit more post menopause, and that is largely because of the connective tissue changes, the changes to the muscle, things like that. Because as we said, it's estrogen that helps give the muscle its bulk, its kind of vascularity. It helps maintain muscle mass. So hence why it's important to be also focusing on your pelvic floor and working on those muscles, okay, particularly in the lead up to menopause, but also post-menopause, to just kind of reduce your risk of more pelvic floor issues happening as you get older. Um, because we also know, even in the absence of estrogen declining, muscles as we get older get thinner. Things don't stay kind of as perky forever. You look at your forehead or your breasts, things like that, things do head south. And the same happens to pelvic organs. So bladder, uterus, bowel, and the muscles themselves become quite thin. So I'm painting a bit of a, excuse me, a bit of a bleak picture. But the point being, that through, your women's health physios, things like that, actually working on your pelvic floor and rehabbing those muscles can be quite effective at reducing a lot of these symptoms, whether it be incontinence or prolapse, etc. Sorry, Dom, I think I went a bit off topic, but was there another
No,
part to the
that's
question?
good. Let's put it in the context of women who are wanting to, hit the gym, whether that be resistance training, running. If they are leaking urine or experience prolapse symptoms, do you suggest working on your pelvic floor first and then getting back into the gym, or can they be done side by side? Talk us to your approach there, because
Yeah. Yeah, so I think it's one of those things, definitely, side by side. I often say to women, they'll stop running or doing their strength training because they are having leaking. And now, obviously, that can be incredibly bothersome and impacting their quality of life. But they're not necessarily doing damage by doing that, okay? You can wear pads and things like that. Now, the question is it going to get worse with time? And that is the big thing. And that's where we come into this, to try and reduce it from happening and making sure that it doesn't get worse. So it's not that if a woman comes in and says, I'm leaking with running, that I then suddenly tell her that she has to stop running. Of course not. But we're going to put some measures in place alongside that, to reduce the chance of this getting worse. What we commonly see, and certainly in all the guidelines that you'll see for, say, pelvic organ prolapse, it will say, as one of the big things from a lifestyle management perspective, it will say, don't do heavy lifting, do low impact activity only, things like that. And so women come quite distressed by that, particularly if they are someone that enjoys weight training, enjoys strength training, enjoys running, and suddenly they're hit with this advice. And they might have seen their gynecologist or their urogynecologist who has reiterated that same advice to them. So I always say it's not that that's wrong, that is what the guidelines are telling us. But certainly we've got to find a middle ground, because for all those reasons, Dom mentioned earlier, it's equally important to be able to keep women exercising, particularly that is cardiovascular strength, because of the benefits of cardiovascular exercise, but also strength training, because we know the benefits of strength training, generally speaking. So often what, like, my consult is looking at with these women, say that have incontinence or prolapse, is we want to make sure that we're starting on some pelvic floor training. So they're doing some pelvic floor exercises based off what we've assessed and things like that. We look at the function of their pelvic floor. So often I'll do a standing assessment, get them to lift a weight overhead while I'm assessing their pelvic floor, which can be on ultrasound, vaginally, or ideally it is an internal vaginal exam that we're doing as they're lifting, say, a weight overhead. We look at their lifting technique, things like that, making sure they're not bracing or putting excessive load down through their pelvic floor when they're lifting, so that we know that it actually is safe for them to continue these things. We can fit them with a pessary, which is basically a little support device that sits inside their vagina. They might put it in before they do the exercise, and then they might take it out after their class, kind of like a tampon, but a little bit of a different shape and size. And then we also look at some other, lifestyle factors that we know equally have an impact on, say, prolapse and incontinence. So if I've got a woman that is horrifically constipated, straining through her pelvic floor to get a bowel motion out every day, I kind of say to her, look, it's your heavy lifting isn't probably going to be doing more damage than your constipation and your straining all day that you've been doing, for the last 10 years of your life. So let's look at some of those other factors like constipation or chronic respiratory issues or issues, with weight gain that all equally, affect your pelvic floor and things like that. And make sure we're addressing that as well, not just taking the exercise away from them. So that's kind of our way of navigating it in a way to just try and find and to meet clients, I guess, in the middle to enable them to keep doing the things they want to be doing because that has so many benefits. But also trying to reduce their risk long term and looking at their pelvic floor health alongside all that.
And one thing you haven't mentioned, but I know is very near and dear to your heart and yours too,
Yeah.
Julia, is local vaginal estrogen.
Yes.
So, and the role that that can play for your pelvic health if there's not a reason to take it systemically, if you're not experiencing any of the other symptoms, or you don't want to take, I guess, systemic estrogen for any reason, which is some people's choice. Can you talk to me a little bit about, vaginal, and I'll get you both to give a little bit of a perspective on what it is, how it might help, risks associated with it. Julia, I'll get you to speak to that.
So topical estrogen, I guess, it's a pessary that a cream that you can, or a little gel cap that you can pop into the vagina that has localized estrogen. And I always like to think that it just makes the tissues juicy and plump again and helps with that sort of tissue strength and integrity. Generally speaking, it's exceptionally safe, and majority of women can use it for a long term without any particular risk. There are a few exceptions to that rule, but most people can use it without any concern. And I have women who use it until they're 90, because it just helps them with their continence and their pelvic floor and all that stuff, which I guess, Alex, you probably see all the time.
Yeah, just reiterating that. I mean, it's such, for so many women, we find it's such a simple thing, particularly with the stress incontinence, where there's many causes that can lead to stress incontinence, which is, as I said, that leaking under load. So say with a cough, a sneeze, a jump, a run. But a big part of what can cause stress incontinence is an issue with your urethral sphincter and basically where the urine leaks out of. And we know as estrogen declines, that urethral sphincter that is affected by that lack of estrogen loses, as Julia said, that plumpness, that closure pressure. And so it can be a real game changer for women that come in with horrific stress incontinence that is stopping them doing so much. And in combination with, addressing the lifestyle factors, you're reducing excessive weight, looking at their bowels, doing some pelvic floor retraining, adding in estrogen, that in itself can be a game changer. And again, no one suggested it. So I find I spend, at least once a day writing back to the patient's GP, really just requesting again, can we have some topical estrogen? And it can make a world of difference in the right client. So it's such an easy thing for us to ask. Obviously, you need your GP to be happy to prescribe it.
Yeah. And I think one thing that, we might have touched on, but I just want to reiterate the link to fractures as well, is with that declining estrogen is part of what they call, the genitourinary syndrome, is recurrent UTIs become more common as your estrogen drops as well. And probably Alex can speak to you more about the mechanism behind that. But it's no coincidence that when we're in, when I was working in the emergency room, a lot of the women who came in with a fractured hip also had a UTI. They're getting up in the middle of the night, they're, stumbling to go to the toilet, whether it's for incontinence or UTI, they trip, they fracture their hip. Or, they're in the elderly patients, they might get delirious or confusion because they've got that infection. Once again, they trip, they fracture. And then, the kind of knock-on effects that we've mentioned in terms of morbidity and mortality impact. So, seemingly really benign things when you're young, like a UTI, become much more serious when you get older. And I don't know age group of the people we're speaking to now, but like this is your future. And so, starting to implement some of those really easy, potentially, I guess, treatments or management tools now can really set you up for success later. So yes, and having recurrent UTIs is awful. It's a really uncomfortable thing. So if there's something that you can avoid or take to avoid having that, that's something that should be a discussion with your doctor. I am going to turn it over to some questions that we got in the lead up, just to cross off some of those, unless we've got any more coming through in the chat. Julia, weight gain in menopause. I know it's something that a lot of people experience. What is that menopause? Is that aging? What can we do?
Yeah, probably a combination of things. I mean, we know that when we've got estrogen in our body, our fat deposits tend to go around our hips. And as your estrogen starts to plummet, it does actually, the distribution changes. And it's actually quite important because not only is it just not on your hips, it's now kind of around your tummy. The fat's a bit different. It's that sort of visceral fat, which we always attribute to being a risk factor for cardiovascular disease and like strokes and heart attacks and things like that. So it's not necessarily that you put on weight, just the distribution changes. But you do lose this some insulin sensitivity with reducing estrogen, and the way that the way you metabolize food does change when you've got reducing estrogen. So I always say to women that if they're worried about their weight changes, you really do need to look at your diet and your exercise. Menopause replacement therapy won't make you lose weight, but it might improve your metabolism and the distribution of the weight. But it's not a silver bullet.
Yeah.
Unfortunately.
Question just came through. Estrogen pessaries, do they get absorbed into the bloodstream or stay local?
We generally assume that it stays local, which is why even some women with particular types of breast cancer, for example, might still be able to use the topicals that go just in the vagina, because we think that it just gets localized absorption. Obviously, anyone who's had breast cancer would need to run that past their specialist, but most women do tolerate with very little risk a localized estrogen.
Okay, one for you, Alex. If you've got no current issues with your pelvis now, what would you suggest we do to keep it that way and maintain pelvic health?
Yeah, I guess certainly looking at those lifestyle factors that we talked about, a lot of people will say, yeah, I don't have any concerns, but I'm horrifically constipated or something like that. So avoiding constipation, avoiding putting on excessive weight, because obviously that puts a lot more load down through your pelvic floor. Generally, staying active, all those things that loads your pelvic floor in a good way as well. If you are someone that you wants to be really proactive, or you're kind of approaching that next life stage, whether it be perimenopause, etc., there are certainly a lot of women that come in and just purely say, I have no concerns, but I want to check in and see where I'm at now, what I could be doing to improve as I'm approaching menopause, things like that. Now that is not accessible to everyone, and so certainly there's plenty of people that will kind of just keep doing what they're doing, and if things do start to change, that's when they intervene. But yeah, certainly, it is obviously easier said than done to just say do your Kegels. Now,
Should everyone be doing Kegels?
Again, not necessarily, because there's certainly plenty of people that doing Kegels will only up train your pelvic floor, and some women actually need to learn to let go of those muscles equally. So it's not as simple as just doing squeezes, and that in some cases can actually make certain conditions worse. So not a blanket rule that everyone should jump on. I think there's a TikToker at the moment or someone on Instagram that's really promoting Kegels, and every second patient's telling me about it at the moment. That's fine, but obviously it isn't for everyone, because there are cases where it
And
won't.
signs that Kegels are not for you. Symptoms that when patients come in with I don't know, specific symptoms.
Mm.
But I've been doing my Kegels, and what makes you think, oh, you're the person who should not be doing these?
Yeah, or should be focusing more maybe on the relax phase of the Kegel rather
Yeah.
than just the contract is classically chronic constipation can be related to a very tight overactive pelvic floor. Pain with intercourse again can be more related to in some cases the tight pelvic floor. You can actually have incontinence from being overactive in your pelvic floor muscles, particularly that urgency or urge incontinence. Turn the key in the door, running water. I'm on my way to the toilet. I'm almost there. I'm pulling my pants down and I start leaking on the way. So in some cases, actually, that does make things worse. Another one is, yeah, pain around the back passage, things like that, that actually doing those exercises is probably going to stir things up further rather than improve it.
Mm, okay. And one interesting thing that I guess you've helped me recognize, and you had a great analogy at another talk that we did. Kegels is one thing, I guess, when you're just like sitting watching TV, but actually when you need to use those muscles is when you are lifting the weights or doing the functional activities. So, sorry.
Or sneezing.
Sneezing or, yeah, jumping on the trampoline with your kids, like that's probably when you need to be learning to activate it, not while you're watching Netflix and feel pretty good that you've done your, I don't know, 100 Kegels for the day.
Absolutely. Like the functional activation of your pelvic floor is probably the biggest thing because we can, routinely we would assess a woman when she's lying down on the bed and we're doing a vaginal exam and she could appear to have quite a strong pelvic floor and great endurance, great coordination. She stands up and we put a weight over her head and she cannot get that muscle to activate in the same way. Or, she leaks when she's standing, not when she's horizontal and gravity's taken away. So it is very important to learn that functional activation of your pelvic floor and be able to coordinate those muscles. And I guess that's where, yeah, your Kegels are one thing, but there's a lot more than just, doing your squeezes, basically.
Yeah. Quick fire. We always get the question, protein. Julia, what's your recommendation from a medical perspective? I know at least the Alternate crew have had nutrition talks before, but I guess just to round things out from your perspective,
Yeah.
protein supplements,
Yeah.
anything you can do.
I like to keep things pretty easy. And so in my head, I have a rough blanket rule of like 1.5 grams per kilo protein as a minimum. But then you see lots of different recommendations. If people are doing heavy lifting, they should have more. If they're not as physical, less. But 1.5 is a pretty good like sweet spot, I reckon.
Yeah.
And how do you figure that out? I guess there's lots of different calculators and things, but yeah, to figure out like a couple of eggs is about 15 grams, but you kind of got to look at the different proteins that you have. The other thing we talked about
And protein only works if you're
if
also
you're using
exercising.
it. Yeah, you've got
Yeah.
to be
So it's
using
not
it.
going to build muscle by itself. You have to
Yeah,
also be doing the
you've got
work.
to move your body. You've got to lift, and you've got to, and as you say, lift what works for you. Just get moving your body. Just move it, because I see so many women who don't. And I don't know, Kieran, maybe not so much where you are because you're at a place where people are motivated to do something, but yeah, just moving your body and eating well is good. Fiber is really important because obviously you need to feel full. You need to have
Yes.
great, bowel actions. Alex has already talked so much about the benefits of the pelvic floor. And then when it comes to supplements and things, I guess there's always individual things like vitamin D, should you be low, but you've got to test for that. But otherwise, creatine is another one that's come up that's been considered as a relatively safe way of maintaining muscle without any particular risks for people. So starting low at about 3 grams a day, so you don't have any tummy upset, can for some women be really helpful to maintain muscle mass.
Yeah. Okay, guys, we are rounding up to our time. I hope this has been useful. As I said, I feel like it's just scraping the surface, but hopefully we've answered some of your questions and given you a little bit of perspective on this stage of life. Quick plug now for Ali. As I said, we're we deal with this all the time. So should you not be able to get this medical advice from your own GP, or you don't have a GP, look us up. See one of our doctors, either Julia or someone else, and they'll be able to work through some of your individual questions, which obviously we can't deal with tonight. And then we're also going to be, we're actually working on recognizing that this issue with pelvic floor is so common amongst women, and wonderful pelvic floor therapists like Alex may not be accessible for everyone. We're actually working on some programs that people can improve their pelvic floor function safely with some medical oversight. So I will send out some information about that should you be interested. So yeah, Karen, I don't know if we covered everything that you were being asked, if there's any glaring questions that you've continually faced that you want us to answer. Otherwise we might call it a night.
No, yeah, that's all good. Thank you very much. I mean, I've learned quite a bit, and I know, a few of the answers, a few of the questions that have come up to me, they've been answered. So it's been awesome. And then, if you guys want to share your details or contacts to myself, I'm happy to share that to our group as well, if that makes it easier as well.
Yeah, that sounds great. Okay, thank you, everyone.